Good morning, good afternoon, good evening to all ladies and gentlemen around the world. Thank you for joining us today for this enlightening webinar about Eustachian tube dilatation, a global experience broadcasted from Overath, Germany. I'm Esther Broder, the product manager for ENT catheters at Spiegel & Theis. Today, we are embarking on a journey that transcends geographical boundaries to explore advancements as well as practical insights and expertise in treating Eustachian tube dysfunction. We are honored to have two distinguished experts here, Dr. Marta Sandoval from Spain and Dr. Martin Nummeler from Denmark. A warm welcome to all of you. The Eustachian tube plays a crucial role in our ear health. Eustachian tube dysfunction, or ETD, affects a significant portion of the population, with prevalence rates ranging from 1 to 5%. Consequences of untreated ETD can be profound. Patients often experience pain, a decrease in their quality of life, and in some cases, it can even trigger more severe pathologies such as cholesteatoma or even hearing loss. This underlines the importance of addressing ETD effectively. In 2010, the innovative procedure balloon Eustachian tuboplasty was introduced to the market. Unlike traditional procedures, it is the only therapy to treat the cause of ETD. According to a study from Schröder et al., BT was effective in more than 70% of 622 patients. Other studies have shown success rates ranging from 70 to 90% among treated patients. We can conclude that BT can be considered as an effective procedure. I understand that safety, of course, is a significant concern when we are considering and talking about medical procedures. A comprehensive randomized clinical trial conducted by Mayer and his team in 2018, involving more than 300 patients, demonstrated that most reported complications were minor and self-limiting, with no serious adverse events reported. BT is not only effective, but also safe. Now, it's my great pleasure to introduce our greatly valued guest speakers who will shed light on various aspects of the Eustachian tube dilatation. Dr. Marta Sandoval, an ENT doctor working at Hospital Clinic Barcelona, Spain, will provide practical tips and insights into indication of dilatation, diagnosis and treatment in balloon Eustachian tuboplasty based on her 10 years of experience and contributions in this field. Following that, we will have Dr. Martin Nummeler from Sørens Hospital in Denmark, sharing his expertise of over 500 performed BET cases under local anesthesia on an in-office setting. So sit back, engage, and let's immerse ourselves in this global experience of knowledge sharing. Please send all your questions, which you may have during the presentation, using the Zoom chat function. And you can also email us at webinar@spiegel-theis.com. We are looking forward to a fruitful and engaging question and answer session after the presentations. Let's now turn the virtual floor over to Marta. Thank you so much.
In this first part of the webinar, I'm going to share some practical tips and expertise about balloon Eustachian tuboplasty and the patient selection and diagnosis. I have been counseling and promoting the Tuboplasty device in Spain, distributed by Suministros Hospitalarios, manufactured by Spiegel & Theis. This is our agenda, which is the background of the Eustachian tube dysfunction, which is the case selection, what is needed for bed surgery, tips and tricks during bed surgery, complications and handling mistakes. And last, I'm going to present the multicenter study that we published in 2023 about 248 patients who underwent balloon Eustachian tuboplasty. since 2009 that Dr. Ockerman and Professor Schulhoff present their first work about balloon dilation of the Eustachian tube in obstructive Eustachian tube dysfunction. There has been a lot of literature published since then. Actually, Eustachian tube dysfunction has always been a subject to be studied and published in medical literature. And for example, in the last 3 years, there has been over 500 references found in PubMed with regards to Eustachian tube dysfunction. First surgeries performed in Spain were in 2011. Then my first case was 2014. And since then, I've done over 150 balloon Eustachian tuboplasties. What does the Eustachian tube dysfunction means? There is a malfunction of the tube, that is, there is no ventilation through the Eustachian tube into the middle ear, which is the function of the Eustachian tube. When there is no this ventilation, there is a malfunction or a dysfunction of the Eustachian tube. We might find an obstructive Eustachian tube dysfunction, which are the obstructive Eustachian tube or the barrier challenge, where we have patients with otic plugging, tinnitus, inability to localize pressures, and on the otoscopy we might find either normal otoscopy, otitis media with effusion or retraction, tympanic retractions, and a patient will have a negative Valsalva maneuver. The tympanometry may be either type A, normal, or with B or C curves showing negative pressures. On the other hand, we have the completely opposite to the obstructive, which is the completely open Eustachian tube dysfunction. There is an opening, a permanent opening of the Eustachian tube, and this is the patulous Eustachian tube dysfunction. In these cases, patients have also otic plugging, tinnitus, autophony of the voice, and on the otoscopy, we will find a flabby eardrum, an extremely positive Valsalva maneuver, and usually a type A tympanometry. This is a patulous Eustachian tube. We see how the patient breathes in and out, how the movement of the membranic tympanic membrane is rhythm with the breathing in and out of the patient. This is the pathognomonic of patulous Eustachian tube. So according to the consensus that we published as well in 2020, according to the Spanish ENT Society, there are 4 indications for balloon Eustachian tuboplasty, which is barrier challenge, chronic serious otitis media, adhesive otitis media with sideways retraction grades 1 and 2, or also patients during, before, or after middle ear procedures. What happened in barrier challenge patients are those patients which are normally in 1 atmosphere of pressure, they have no any complaint, but when they are subject into a change of the atmospheric pressures, patients have complaint. What happened when this happens is when patients dive in divers, or when they fly in aircraft crew or aircraft passengers, or all those patients that or staff that work in hyperbaric medicine. When they are treated under hyperbaric medicine, when the atmospheric pressure increases and they need, and is when they show the barrier challenge problem. Second indications will be in chronic serious otitis media in patients that have already received previous ventilation tube, that they have already been operated with previous ventilation tube. These patients have middle ear effusion with Valsalva, with negative Valsalva maneuver. So we will think about balloon Eustachian tuboplasty in all those adults that we have already performed 2 ventilations to previously, or in children when we have done already 3 ventilation tubes. And when we have to think about the balloon Eustachian tuboplasty. Actually, nowadays, it's thought that it's controversy to see which is the beneficial of ventilation tube together with balloon Eustachian tuboplasty. Some authors don't recommend the ventilation tube, and also Some authors, as Formankova and her team in 2020, they did not recommend either tympanocentesis during balloon Eustachian tuboplasty because it's not beneficial into a long-term outcome, because the tympanocentesis only allows to remove the mucus or the effusion in the middle ear, but does not improve the Eustachian tube function. The second indication will be adhesive otitis media in those patients where we find retraction of tympanic membrane retraction grades 1 and 2. Will be those cases where the tympanic membrane can be lifted off the promontory during a Valsalva maneuver. And fourth indication will be a balloon Eustachian tuboplasty associated to middle ear procedures during tympanoplasty in those patients when we had already done a previous mirroring or tympanoplasty and there is a reperforation. We will think about bilateral balloon Eustachian tuboplasty, or when we have an anterior perforation. Also in those patients where we have a cholesteatoma secondary to a malfunction of the Eustachian tube with retraction, adhesive otitis media, important retraction, and finally cholesteatoma. And also those cases where there is an otorrhea or problem in the ear, always related to tubal dysfunctions, in those patients where they have rhinopharyngeal intercurrent processes and they cause otorrhea or ear discharge. So we will think about this balloon Eustachian tuboplasty. And in these cases, for us, it's very important to check how is the contralateral ear, how does the contralateral ear behave during these rhinopharyngeal processes. C et al. In the group and in his group published in 2019 that these adhesive otitis media patients will not relieve their symptoms only with bed, because cartilage tympanoplasty should be added to the bed procedure to improve or relieve the symptoms and tinnitus and ear stuffiness of these cases. This is the clinical evaluation that we are going to go through. First of all, which are the symptoms of the patients? There is an otic plugging, tinnitus, hearing loss, inability to localize pressures. We need to ask the patient what happened when the patient dives or when the patient flies in an aircraft, see which is the behavior of the ear, if he complains of barotrauma or any other problem. What happened with the otitis media with effusion or chronic serious otitis media, how long last these episodes, and also what happened in this situation in patients with adhesive otitis media. This is the otoscopy of the patients, might be either normal, we might find a middle ear effusion or a retraction, but always the otoscopy is needed and needs to be reported in the chart. Valsalva maneuver also very important. We need to make sure that we teach properly to the patient how to perform properly the Valsalva maneuver. I take time, I repeatedly explain the patient. Sometimes I need 2 visits and I delay the visit at least 1 month from one to the second one to see that the patient has properly learned how to perform this Valsalva maneuver. Sometimes they do a twin pin maneuver as well, which is following with the nose pinch in between the Valsalva maneuvers to see as well which is the movement. And Frenzel maneuver is more difficult, is the movement, is the anteriorization of the larynx during scuba divers. This is a maneuver properly done by scuba divers. I never ask the patients to do this maneuver. Nasal endoscopy is mandatory in the physical exam. We need to see how is the anatomy of the fossa. We need to rule out if there is any pathology, any nasal polyps, maxillofacial malformation. We need to evaluate how is the torus tubarius. We see like there is a retraction or a scar of a previous adenoidotomy, and we need to make sure which is the feasibility to insert the inductor of the balloon, so that we can properly introduce both the scope and the inductor in the nasal fossa of the patient for the procedure. We do always an audiogram in the otology patients in our clinic, despite audiogram is not needed for the bed procedure, because usually we do not improve audiogram because those patients currently have hearing loss due and the audiogram does not improve only with the balloon Eustachian tuboplasty, but very important to do the tympanometry either before and after the Valsalva maneuver. We might have type A, B, or C curve, so we need to report it as well. And last, we need to assess the Eustachian tube dysfunction questionnaire, which was validated and published in 2012 by McCool and his team. And since then, there has been many translations into all languages that we might find. Herrera translate and validate this questionnaire into Spanish, and it was published in 2019. There is a lot of languages which this questionnaire is validated, in Malay, in Arabic, in Turkish, and Brazilian Portuguese, in Portuguese. So either language you might have, you will find a validated and translated ETD Pure 7, and if not, validated. This questionnaire is a 7-item questions with a qualification from 1. There is no problem of the patient up to 7. It's a severe problem, so we might have a score up to 49. And usually we found it pathological above 14. Which is the success of bed depending upon the indication. We might have better challenge or chronic serious otitis media, which are easy cases to indicate the tuboplasty with balloon, and we might have good results. We might have patients during, before, or after middle ear procedures where it's more difficult to measure the result and difficult to see a beneficial straight from the bed. And adhesive otitis media grades 1 or 2, they might have both behaviors, either good results or in easy cases to indicate, but sometimes it's also difficult to indicate a bed only in these patients with grade 1 and 2 adhesive otitis media. What do we need to do this procedure? We do it always under general anesthesia. In my case, always under general anesthesia. We use a proper topical nasal vasoconstriction with anesthesia with nasal pads. We put them once the patient is already intubated, and before scrubbing, we use the nasal pads with vasoconstriction and anesthesia. We don't need extra equipment for the surgery because everything comes with the Tuboplasty set. I only add, for example, a suction tip and a freer dissection in case I need it. We will have in the surgical table also nasal pads in case we need them, because sometimes we might cause a little hemorrhage or nasal packing. And we will need, of course, a nasal endoscope, either 0 or 30 degrees with a camera and a recording system if it's pushed. Which are the tips that I recommend? Usually a good topical vasoconstriction, especially in the tail of the inferior turbinate. You see how the nasal pad reaches up to the rhinopharynx. This is with topical anesthesia, is what we put in the nasal fossa of the patient before scrubbing. Yeah? We avoid any traumatic bleeding and insert the inductor very carefully in the nasal fossa, and we need to make sure that we place correctly the balloon inside of the Eustachian tube. I'm going to give you a video. I'm going to show you a video here of how we should not do balloon tuboplasty. You see how this is one of my first cases. I'm fighting in between the inserter and the scope. I have no proper view of the entrance of the Eustachian tube. The torus tubarius is not very clear. I'm fighting. And this other video is the same patient when I have already have a good view of the torus tubarius. I have a good view of the entrance of the Eustachian tube. So my recommendation, if you are starting fighting for the visualization, stop, remove the scope, remove the inserter, and start over again. Once we have inserted the balloon, the inserter in the entrance of the Eustachian tube, we proceed to place the balloon through the inserter. We push it gently through the inserter. So in this case, the balloon releases from the inserter up to the Eustachian tube. Once it's already introduced, we inflate the balloon by applying 10 atm pressure for 2 minutes. This is what it's recommended for the manufacturer. This is how we always do it. This is a QR where you can scan it and watch a video. It's in YouTube about the procedure. How do I do it? So if you have any doubt that you haven't done it properly, do it again. I do not recommend personally to perform a CT scan before, and I prefer to remove the balloon inflated. Both cases is not is my personal preference, but it's not according to the manufacturer. Spiegel and Zeiss does recommend to do a CT scan previously and to remove the balloon de-inflated, but I remove it inflated because it makes me feel more comfortable, because it gives me more assurance that the balloon has been properly inflated and introduced in the Eustachian tube and ensures the integrity of the balloon. This is how I remove the inserter with the balloon inflated. I see this mucus in the balloon. I really like to see how this mucus come out of the Eustachian tube. Complications are not very usual, are seldom. We might have usually slight nasal bleeding. I usually put some nasal pads in the post-op if I see some kind of lesion in the septum or in the inferior middle turbinate. I put this nasal pad for 1 or 2 hours, and usually before the patient is discharged from the hospital, I remove these nasal pads. If I see there is some more important bleeding, I might leave the packing for 1 day, for 24 hours. And another complication, which is seldom as well, is very mild. It's not severe complication, is a subcutaneous emphysema. And usually it's due to the that the patient performs the Valsalva maneuver too precautiously. That means patients needs to perform the Valsalva maneuver after the bed procedure that has to start after 24 hours of the procedure. So that means that the patient sometimes, in these cases, reported with subcutaneous emphysema. Usually the patient performed the Valsalva maneuver too early after the procedure. So very important to advise the patient not to do it. Other handling mistakes that we might have with the balloon, we might have bending of the balloon due to the introduction is too forced in the inserter. That means that it's the inserter has not been properly introduced in the Eustachian tube, and we force too much, or the scrub nurse or our assistant force too much the insertion of the balloon through the inserter, or we might have a puncture of the balloon. That means that we have not properly handled the balloon. This is very seldom. It happened to me, I think, 1 or 2 times, not really too much. What we see is that there is a dropping of the water through the balloon, and what we see in the pump, due to the balloon is inserted in the Eustachian tube, we might not see what happened. We see how there is a drop from the 10 atm that the pressure is raised for 2 minutes. We see how this pressure drops every time. You can increase the pressure again through the pump, but we see how it drops and drops and drops and keep dropping. So you need to rule out if the balloon is functioning. So my last part of the presentation will be to discuss a little bit the results that we have in this retrospective multi-center core study of 248 patients, where Dr. Navarro, Dr. Martinez, Dr. Herrera, Dr. Alfaro, Dr. Lopez, Dr. Marco, and Dr. Plaza, we all bind together to do this paper, and we put together 248 patients, in total 319 procedures. It was published online in February 2023. It's a retrospective multi-center study, and the indications that we select were the first three. We'll remove the indications of during bed, during, before, or after middle ear procedures, because it's very difficult to measure the outcome, and we decide to remove it. So we stick with the indications of our challenge, chronic serious otitis media, and adhesive otitis media, grades 1 or 2 of SADE stratification. We measure the outcomes of the otoscopy, tympanometry, the ETDQ7, and the Valsalva maneuver, and it was reported at baseline 3, 12, and 24 months after bed. And p-value was considered statistically significant when it was 0.05. This is the demographic of our study. 62% of the patients of the cases were males. Of the patients were males. Most frequent indication was chronic serious otitis media, with a 52%, almost 53% of the cases, followed by baro challenge situations, and the less frequent indication was adhesive otitis media. The point that our study brings into the literature is that we present the results in global, but we present the results as well separated for each of the indications. So we have a result in each one of these outcome measurements in each of the indications. Our global results were that otoscopy, tympanometry, ETDQ7, and the Valsalva maneuver, all of them improved significantly, statistical significantly. Then when we split the results in order to see which is the result of depending upon the indication, we see that in the baro challenge group, there is no variation on the otoscopy, because these patients most of the times have normal otoscopies. That's why there is no variation. The tympanometry, ETDQ7, and the Valsalva maneuver improved in a statistical significance manner. In the chronic serious otitis media, we see a statistical significant improvement of all 4 outcomes. And in the adhesive otitis media group, we see a statistical improvement of the otoscopy, tympanometry, and Valsalva maneuver, but no in the questionnaire. Why? Probably according to what C et al. Published in 2019 in this article that we have already talked about in previous slides, where these authors recommend in adhesive otitis media, if there is no cartilage tympanoplasty associated, most of the patients might not improve the subjective symptoms like ear stuffiness, tinnitus, or ear otic clogging. These are the percentage of the results at 3, 12, and 24 months. We see the global results, very important to see how they improve up to 86% at 3 months, but this improvement is maintained or even improved up to 90% at 2 years after the procedure. In baro challenge group, we see that how the patients improve, but at 2 years follow-up, all the patients that were follow-up for 2 years, they improve. In the chronic serious otitis media group, the results are not as good as in baro challenge group, but they improve up to 85%. And these results maintain stable along the years, along these 2 years of follow-up. And in the adhesive otitis media group, it seems to improve at the beginning up to 88%, which is a very good improvement. But up to 2 years, this improvement drops down to 79%. So in these cases, despite it's a good result, it's a good improvement, which improvement means as well in these patients, the further ventilation tube is not needed. Which are the take-home messages that we have to take? Is a proper diagnosis of the obstruction. We need to rule out the pathologous-Eustachian tube. We need to make sure, very important, make sure that the Valsalva maneuver is properly done. Do the Eustachian tube dysfunction questionnaire, tympanometry, endoscopy, and report it in your patient report in the chart. With regards to the results, the best patients, the gold standard will be for Barrett challenge, but also for chronic serious otitis media will be the second best results, and the third best results are for adhesive otitis media. We recommend as well to evaluate long-term results. In our case, we did it 3, 12, and 24 months, but it would be also very interesting to see a long follow-up. So thank you very much. We will attend questions at the end of the presentation. This is my email in case you want to contact me. Thank you.
So let's begin on the part of Eustachian tube dilation in local anesthesia. I am Martin Møller. I'm an ENT consultant in central Copenhagen, Denmark, on the private hospital called the Hospital at the Lakes, which is situated at the Lakes in central Copenhagen. I'm an associate professor formerly at Rigshospitalet and a clinical lecturer as well. And I've been doing Eustachian tube dilation since 2014, and since 2017 I've been doing it in local anesthesia and have been doing it ever since, really. First, let's discuss the epidemiology of Eustachian tube dysfunction. Roughly 5 to 6% of the world population has Eustachian tube dysfunction, but if you look at the leisure-related Eustachian tube dysfunction, such as problems when flying and dining, it's more likely to be 70% or even as high as 20%. We could call this parotitis. Whenever you're pressurized, the Eustachian tube has problems following up, and you will have pain in ears or muffled hearing or even burst tympanic membrane. If you look at the United States, approximately 2 million visits per year, or 0.6% of the population, are going to the ENT practitioner due to Eustachian tube dysfunction. If we look back on Denmark, we have roughly 30,000 visits per year, which is approximately 0.5% of the population going to the ENT practitioner due to the Eustachian tube dysfunction every year. We perform about 350 procedures, which is only really 0.005% of the population that receive treatment. So let's look how we treat patients today. In the developed world, we have about 2 billion people, and roughly 100 million of those have Eustachian tube dysfunction, and around 10 million will go to the local ENT practitioner every year, but only 100,000 patients will get a dilation, which is corresponding to 0.005% of the total population, which is quite low. So what may be the cause of this mismatch? Well, there are several causes of it. Insurance companies may reject procedure to the very high cost of going to the hospital to get full anesthesia, the cost of the balloon, the transport back and forth. You all know the capacity and prioritization that happens. I know all of you maybe have some problems going to the theater and get theater times. Even the physicians may reject hospital referral to the lack of knowledge. No referral reimbursements. Maybe the patient or the physical state of the patients relative to anesthesia may be a problem. And also the patient may reject treatment because of fear to the general anesthesia, the distance to a hospital if it's not done locally, waiting time. In Denmark, it's up to 1 year, maybe 2 years waiting time. You need days away from work when you go to full anesthesia. You need transport back and forth from your next of kin. You need rearrangements to get them back and forth. And of course, the high procedure costs if you want to do it by yourself. So how can we offer the Eustachian tube dilations to more patients than today? Well, if you look at the local anesthesia option, then suddenly you become aware that the insurance company may not reject the procedure anymore because of high cost, or the capacity on your theater is not a problem anymore. And also the physical state of the patients in full anesthesia is no longer a concern. And also for the patient's point of view, the fear of general anesthesia is no longer an issue. You don't need days away from work. the procedure cost is now significantly lower when using local anesthesia than in full anesthesia. So let's take a brief look at the procedure setup in local anesthesia. In my setup, I require 3 persons. The balloon insertion device is handled by the physician, which is me often. I use a digital endoscope handled by the first assistant. You can see that in the video in the next slides or 2. I need a balloon pressurization device to be handled by a second assistant, and the procedure is visualized on the digital monitor, as you all know. Of course, you can use a stiff endoscope. I'll come back to that in just 2 seconds. Now, this is the standard procedure setup in local anesthesia in my clinic. I use a flexible digital endoscope and a standard digital monitor for visualization, and then I use the speaker-lensized Tuboplasty. I use the children's editions because it is slightly smaller. You could, of course, use the rigid endoscope, but if you do rigid endoscopy in the nose in local anesthesia, some patients will have slightly more pain, and you will have a problem in some patients with a just even slight septum deviation. So I prefer the flexible endoscope. I'll come back to that in just 2 seconds. First, let's discuss the procedure setup in local anesthesia and the patient selection for local anesthesia. I do the procedure only in adults, but in the occasional case, I would do older kids, 15 plus maybe, and they may be able to comply. They should be able to handle endoscopic procedure before I can proceed. No patient should have a severe septum deviation because of the pain caused by going around the severe septum deviation. Even more so if you use a rigid endoscope. They should have no medical allergies against benzodiazepine primarily, and of course paracetamol and non-steroid drugs. No severe asthma, chronic lung disease, or myasthenia gravis due to the benzodiazepine. However, pregnancy is not a contraindication in local anesthesia, and ASA class 2 to 4 is also not a contraindication in local anesthesia. And this is the Copenhagen protocol. From patient arrival, we start out with pre-medication at least 20 minutes beforehand. I would like to give it maybe 30 minutes beforehand. Some will do 40 minutes beforehand. The first medication that you want to give is oxazepam or a similar product. This is very important because of the blockage of the vagal nerve and then the prevention of bradycardia and the low pressure. Also, I use 400 milligram of ibuprofen or similar, and I use 1 gram of paracetamol. Sometimes I use a little bit of morphine as well. It's just optional. I find that this has no really effect on the pain scale, which we come back to in 2 seconds as well. From there on, I use phenylephrine soaked pledgage in the nasal cavity for 10 to 15 minutes. I, after that, use xylocaine spray in the nasal cavity, and that's it for 2 minutes. I try to get it around the orifice for the Eustachian tube. And then immediately after that, I perform the procedure, and after that, the patient is immediately discharged. So in total, that will take me around 45 minutes from patient arrival to patient is discharged as well. In some cases, it may take an hour, depending on the pre-medication handed out before 20, 30, or 40 minutes around. And then I think we should see just a short video of how the procedure is actually performed in local anesthesia. You can see this is the patient removing the pledgage from the nasal cavity. See, I'm talking to the patient and my assistants. So my right assistant, the nurse, I've taught to do flexible endoscopic procedure. So this is very handy. And of course you can do this by myself, but not with the flexible endoscope. I need a third assistant to do the flexible endoscope. The flexible endoscope is my preferred visualization method because of the less pain caused by the flexible endoscope, and even if you have a slight septum deviation, you may be able to do the procedure as well. So, and the patient is totally aware of what's going on. It's very important to inform the patients what's going on, how the instrument is coming into the nose, how it's coming into the station tube. It's very important to inform the patient of when you insert the device in the station tube, there will be some pain, and when we inflate the device, there will be some pain as well. And as you can see, my assistants to the right will guide the endoscope with me, just doing fist surgery like that. This is just with a flexible endoscope as well. And you can see the balloon is going out to the station tube now, and I'm just informing the patient that now the balloon is going into the tube, and then the pressure is coming on. You can see the balloon is inflating right now. And we keep it there for the standard 2 minutes. This is not a part of the video, so the video will just go on, and then we deflate the balloon and retract the balloon with visualization, just as you would do with a digital rigid endoscope. And take a look at the patient. You will get a smile. We get a small smile. Fantastic. The patient did a fine job. So within just 2 minutes, the procedure is done. We can move on to the second ear if that is required, or the patient will, after this, just be discharged. After that, we can discuss the results in local anesthesia, the procedure success rate. We've been doing more than 500 procedures since 2017 using local anesthesia only. I rarely do full anesthesia. That's only because of the severe septum deviation, or if the patients cannot handle local anesthesia. We've had no adverse effects. Some, of course, small, minor nosebleeds, etc., but nothing big at all. We did have no vasovagal shocks, no loss of blood pressure, low heart rate, anything like that. And if you ask the patient, would you have this procedure done again in a local anesthesia setting, 96% says, yes, we would like to do it again in a local anesthesia setting. If you look at the pain score, most patients will say VAS score, a visual analog scale from 1 to 10, or 0 to 10. Most patients will score 4 to 6. Most patients scores 5. And the patient will typically say the pain occurs when entering the station tube and when pressurizing the balloon. After that, the pain will diminish over time, and when the 2 minutes has passed, there's almost no pain at all. So very easy, no severe pain, even though we only sedate a little bit with benzodiazepine and then only uses spray for local anesthesia. And then move on to the results, the patient success rate. In total, we did 517 patients since 2017. We did 124 patients with purely leisure-related problems, which is about 200 procedures, counting both ears. This is the varicositis-related problems. 10 had a second procedure done in total, and only 5 patients could not perform the procedure in local anesthesia. Those were all because of pain related to a more or less severe septum deviation. On the results on the dysfunction part, 69% resolved from type B to C tympanogram to a type A. 82% improved significantly on the Eustachian tube dysfunctioning questionnaire, and 63 had more than a 20 dB pure tone average improvement. Now, if you look at the results on only leisure-related dysfunction, flying and diving and so forth, 96 reported an improvement. 94% had a significant improvement on the eustachian tube dysfunctioning questionnaire. So these are very, very, very good results on this specific part that only has problems when they fly and they die. So can we do eustachian tube dilation in local anesthesia? And if Barack Obama says, yes, we can, then of course, yes, we can. The patients are happy. It's a straightforward procedure. From patient arrival to discharge, roughly 45 minutes, maybe up to an hour. There are no significant pain. Pain score is around 4 to 6 on a scale from 0 to 10. Most pain will be when entering the eustachian tube and when dilating the balloon to the 10 or 12 atmosphere. Then the pain will diminish, and then you can retract the balloon without significant pain afterwards. You can choose to do the procedure in local anesthesia using a flexible endoscope. I would recommend using a third assistant, otherwise it's difficult. You can use a rigid endoscope if you want to, of course, but then you should be informed that in just mild to severe septum deviation, you may run into some problems on the pain scale when hitting the septum. You need a steady hand, but it's possible. I've done it many times, but I prefer the flexible endoscope in the correct setup with the third assistance. So that's my talk on the eustachian tube dysfunction and the eustachian tube dilation in local anesthesia. Thank you so much for attending this webinar with Spit Van Thijs, and I'll be happy to answer any questions. Just let me know.
Thank you so much, Dr. Marta Sandoval and Dr. Martin Nummiller, for your impressive presentations, sharing with us your vast experience with eustachian tube dilation. And I would like to address to the participants in the audience that you still can drop your questions in the chat or Q&A function to be answered by our experts. So don't miss out the chance and opportunity for that. We already received plenty of questions, so let's just start with this and have a look at the questions from the audience. So some of the questions are particularly addressed to one speaker, and others are addressed basically for both of you. So yeah, I will guide you through that. And the first question goes to Dr. Marta Sandoval. So what do you do when you think it's impossible to reach the torus tubericus due to a septal deviation?
That's a good question. It depends. Usually, because we have done the nasal endoscopy preoperatively in the office, we might think that we might have this problem. So I always advise the patient, there is a septal deviation, I might have problems, it might be difficult. So I always advise the patient that first, I can probably not be able to perform properly the dilation. And second, what I will do, it hasn't happened yet to me as yet, but what I will probably do is an endoscopic septoplasty, remove the spur or then remove the slight deviation to allow me to go into the torus tuberous. So I always advise the patient that we might probably end up doing an endoscopic septoplasty in case it's needed. I haven't done it as yet, but I usually advise the patient when I see it in the clinic.
Thank you so much for this answer here. We received another question. So this is basically open for both of you. If patients need a second procedure, in what time interval from the first procedure can the surgical intervention, the BET, be done? I don't know who would like to answer first.
I usually wait 1 year. But you can do it earlier. I would say after a couple months or after 3 months, it's when the maximum effect of dilation is achieved usually at 3 months. So I will wait these 3 months at least but I usually wait 1 year.
Yes, I agree. 6 to 12 months before I do the second procedure if needed.
Okay, thank you. Then another question we received from the audience was, despite there is, I think this also refers to Marta, because she talked about the consensus, the multi-center study. Despite there is not an indication, as you say, in the consensus, what do you do with patients affected with more severe tympanic membrane retractions?
I do the balloon Eustachian tuboplasty plus cartilage tympanoplasty. So I add cartilage tympanoplasty. Those patients will fall in the fourth indication, which would be before, during, or after bed middle ear procedures. So I will do a cartilage tympanoplasty. I start doing first bed and then delay the middle ear surgery like 3 months. And then I am doing it now in one same procedure, both. But now I'm thinking to change again and do the bed first and then the middle ear procedure.
Oh, wow. Thank you. Now I think the next question goes to Martin Nummeler. Shirley asks for BET under local anesthesia. Do you perform a CT scan previously?
No, we do not. We used to do that when we started out in 2014, but the study that came out in 2013, actually from Germany, showed that in 2000 CT scans, there were no issues with the carotid artery, so we don't routinely do CT scans at all anymore. Even in full anesthesia or local anesthesia, it doesn't really matter.
Okay, thank you. And just a comment from Jaco. He said that it's a very good idea to use a flexible endoscope in office cases. So that was just a comment from him, but worth mentioning. And another question from Thomas is if there is any age limit in children. I don't know what your experience are with children BET, but maybe both of you can say some words about that.
Yes, I can start out. The age limit for children is, in our case, 2 years. Because of the anatomy in children, it's not really good to perform that in age 0 to 2 years. So after 2 years is possible with the small balloon, I think. Yes.
In my case, I haven't done any procedure in children under 10 years of age. Because in our consensus, we set up that children should be considered for bed after the third ventilation tube. So it's kind of, I don't have patients where I had to place a third ventilation tube below like 8 or 9 years of age.
Yeah, very interesting.
I always, and of course in pediatric patients, I'm always very concerned about the adenoids. And adenoids usually do not reduce until more or less this age, usually in most of the children. And they don't know also how to perform the Valsalva maneuver. It's kind of difficult. So I try to teach them very well how to perform the Valsalva maneuver.
Oh, yeah, it's interesting to see two different opinions from 2 different countries. The next question goes to Dr. Martin Nummeler. What is the recommended diameter size for the flexible endoscope? I think the flexible endoscope received here much attention in the question and answer session. I see many questions about that.
So I use the smallest diameter possible. You could go up, of course, but a diameter of 2.7 millimeters. I use that one if I can. And that goes well with the children's edition with the SpeedLine's highest insertion instrument. So you have a very small diameter on both instruments, which is really preferred on these patients, even though you may get a little bit better visualization on the big diameter endoscopes. I prefer to do the smallest possible, really.
Okay, great to hear that, and that makes totally sense. We got a question from Janos. I hope I pronounced the name correctly. What are the chances of having an open Eustachian tube after BET was the question.
In my case, it's very, very rare. I may have been 1 or 2 patients since 2014. So if you choose your patients correctly, that's the main thing. It might be possible that these patients even had a Paschal's tube before we did Eustachian tube dilation. So if you choose the patient correct, I haven't had any cases in the last few years.
Completely, 100% agree with Martin. The importance of the selection of the cases. I haven't had any pathological Eustachian tube after dilation.
Yeah, interesting to hear that. Then we received a question from Javier. I mean, diagnosis is crucial in BET, and he is wondering, how do I make the Eustachian tube obstruction diagnosis correctly? So that was his questions to you.
Yeah, I can take that question. First of all, for me, the most important part is the symptoms of the patient. What does the patient complains about? Second is when this happens, which is what is the trigger of the symptoms of the patient? If it's a viral challenge, usually you have to ask what happens when the patient flies or climbs a mountain or drives all the way high up in a mountain as well, or during scuba diving in case they scuba dive, which is not that common. Second is how long does this last? No, it's chronic serous otitis media, just a mild ototuberitis. So very important. Which are the symptoms and the complaints of the patient? Another important point will be the Valsalva maneuver. Does the patient know how to perform the Valsalva maneuver? Do you see how the patient is doing the Valsalva maneuver while you are exploring? I use the fibroscope for otoscopy in these patients. So I check while I'm seeing through the screen the ear, what is the movement of the tympanic membrane. I try to see as well, how do they do the Valsalva maneuver if they do it properly. Those are my most important points. Then the ETDQ7, the tympanometry, the otoscopy, everything is important, of course, and have it reported on the chart. But these will be my 3 main symptoms, when did this happen, and the Valsalva. You have to focus on this.
Very helpful, very helpful. Then we received another question. Can grommets be avoided if you do BET instead? So that was a question from Rajendra.
The answer is yes and no. In some cases, yes. That's the whole point for some patients, but it's not a 100% procedure. So in 20, maybe 30% of the cases, no, it cannot be avoided.
Okay, great.
I don't usually add.
Oh, sorry.
I don't usually do the BET together with the grommet. So I do the BET in case that the patient has a lot of hearing loss because of the middle ear effusion. I do a meringocentesis, which means remove the effusion, and I try not to put the grommet at that same procedure. And I wait until the patient knows how to perform the Valsalva maneuver, that everything is well done. I, for example, remember one patient who went under BET and he had an effusion in the middle ear and he had to go into court next week. So he needed like the grommet because he wanted to go into court hearing perfectly. So I placed the grommet in that case, but not in the spring. At the same moment, I don't place grommet anymore.
Okay, thank you for this really helpful answer. We received another question, so it's getting very busy in the question and answer session here from Dr. Lee in Taiwan. So he is very kind of pleased to hear the experience from you, Dr. Martin Nummüller, BET under local anesthesia. And he has even three questions. Maybe I start with the first. Have you ever done BET under local anesthesia without oral painkiller? Is the first question.
I have. The oral painkillers are not that important, actually. The main thing is that you use a benzodiazepine. That and local anesthesia, spray or platelet or whatever you want to do is the main thing to do. If you use paracetamol or non-steroid anti-inflammatory drugs, it just helps a little bit. I find if you use cytokine gel, if you put that around the orifice of the eustachian tube, that may actually diminish the pain scale additionally 1 or 2 points. So if possible, you should do that. If you want to give the patient the most pain relief, I think you should try to put some oral painkillers as well, but it doesn't really mean much.
Okay. Then his second question is if you perform myringotomy before BET regularly. I mean, this is also kind of interesting as we had also something mentioned like this in Dr. Marta Sandoval's presentation.
Yes, I do. I do regularly, yes. And we can even prove that if you choose, again, the correct patient group, if you do eustachian tube dilation before air surgery, you will have significant better results.
Okay, thank you. And then the last questions he has is that what is the maximum number of BET per person in your experience? Like how many revision cases? And I think this would be a question also for both of you. And then he is interested, when will you decide to do it again? To what are the indications, so to say, or the factors when you decide to redilate a patient was previously undergone BET?
I haven't done any cases more than twice. I don't think you should do a third time, but that's my opinion. If you don't have any success during the second in an adult, I don't think you should choose to do a third dilation in this patient. You should choose another course of action. And again, like I said before, I don't do anything before at least 6 months for a second dilation.
I agree completely with him. No more than 2 times.
Okay, not more than 2 times. Then we received another question here. Like I also have to look for the time. We only have 2 minutes left, but just in case if we have not answered your question, you will receive them by email. So don't you worry. So all questions will be addressed as we have just limited time. And some more information that the webinar is obviously recorded and will be also available to everybody on our website. So basically on the Spiegel and Theis website, you have then the button news and webinar, and then you can access it and share it also and with whom is interested. So we have another question from Sarita. She's asking if there's any reason why the speakers do not dilate the eustachian tube of young children, and if you dilate the eustachian tube of elderly patients with chronic serious otitis media that need revision. Yeah, but I think Marta, you already kind of pointed out with the children.
I'm sticking with the consensus that we might probably have to review it in a short time probably, but our consensus in the ENT Spanish Society consents that BET should be considered in children whenever we have placed already 3 ventilation tubes previously. So I do the Eustachian tube dilation when I see the patient is more candidate to improve. So in my experience, I haven't done it when children is younger than 10 years of age, but I'm open to see other children as well. So, but it's difficult to get a patient with 3 ventilation tubes earlier than 6 or 7 years of age.
Okay, so then the last question we will answer here in that round is from Italy, from an Italian doctor who asked if you had a way to objectively assess the physiological pressure equalizing function of the Eustachian tube in your examination. Would you incorporate that into your pre-surgical workup? So you start.
Actually, we have some Danish guys coming up probably with a new device within hopefully a year or two that can visualize the Eustachian tube functioning quite like you do with cardiorespiratory monitoring as well. So yes, absolutely. We need some tools to define Eustachian tube dysfunction properly, objectively.
Yeah, tympanometry is not more available in the market, so it's something that we have always been looking for. If there is any company or something that develops a device to measure this, agree with Martin.
Yeah, thank you so much. We are very happy to see so many questions. It really shows the great interest in the topics presented by our speakers. I hope this session was very informative and also helpful for you. And thank you again for listening and engaging in the question and answer session. Yeah, so your question again, which are not answered yet, will be provided to you. And yeah, thank you so much. Goodbye and take care. Bye-bye.